Hello and welcome to Module 2 for the Level 1 VR teaching sessions, our foundation teaching sessions. You can find Module 1, which just introduces you to vocational rehabilitation. So in terms of aims for this session, we want to think about kind of what constitutes as good work, explore the guidelines around VR from the stroke clinical guideline point of view, look at the kind of national service model and how it links to VR. Then I'm just going to introduce the 3-level model and think just about kind of how we might consider adding some aspects for a VR pathway in our stroke services. So just a quick reflection again. So what makes work good from our perspective? So what do we think makes it good? We've talked about in our other module why we work, but what makes it good? So here is what we said in our training. Teamwork, meeting new people. You'll notice that cake is fairly bold there. So obviously a few people have said cake makes their work good. They think having supported management, service development and having variety and learning. So just from RCOT again, just saying that a safe working environment with job security, financial job security, a bit of control over what decisions affect your life, making those positive social connections and good working relationships, whether that's from your colleagues or management, and having work that's appropriately challenging for us as well. So really important. So I just wanted to touch a little bit on the National Clinical Guidelines for Stroke, which obviously published last year. The guidelines themselves are an evidence base to help create kind of robust policy. In 2023, there's very clear guidance that supports VR. And also included in our national SNAP data as well to help us kind of persuade that need for rehab and delivery of good quality rehab for stroke. So I guess thinking about vocational rehabilitation and what it says in the guidance, this is probably the most important part, is asking about pre-stroke work at the earliest opportunity. So I think it's considering where do you fit within the stroke kind of journey. Is it at that very acute, hyperacute phase, or is it kind of follow-up clinics like life after stroke type phase? You know, we need to think about work at every aspect, and I think sometimes people, or we're all guilty of forgetting or maybe just not thinking it's a priority, but often patients have come in and had a stroke and the first thing on their mind is thinking, oh, what am I going to do about work? So it's just being able to ask them about it and then being able to reassure them that there's things in place that you can support them with. So this is basically just what it says that people should be able to, people should be able to do after they've had a stroke. So understanding the consequences of the stroke, have an appropriate professional, normally it's one link professional that helps them with work, what their work requirements are with their employer. They might need to work out what their sick leave policy is. Going to need to be assessed on work-related skills and competencies to look at like their potential to a return. They need to be actively able to participate in the discussions and decision making. We discussed that kind of in some of the definitions around VR in the first section. And sorry again, my little video bubbles over the top of some of the writing, but they should be able to be referred to a national, a VR service, which, you know, is in our guidelines but doesn't necessarily always exist, and be able to be signposted, kind of HR or charities, legal advice, that sort of thing. So if we just consider what services that support people with stroke to return to work should be able to ensure, so this is kind of like the gold standard of what we should be providing. So we need a coordinator. We need to make sure that workplaces offer to provide that adaptation in line with the Equality Act. And we need to make sure that the programmes that we offer should look at assessing those potential barriers and facilitators to return to work, build an action plan of how we can overcome them, and complete obviously those interventions as required based on whatever the individual needs. We need to collaborate between the person with the stroke, their employer and healthcare professionals in the team to be able to plan them getting back in, facilitate them going, and then also continuing to monitor their return to work. This is quite tricky because we often have quite specific pathway lengths in our services, so sometimes we haven't got the ability to get them to a point where they've planned and returned and then able to monitor them. And again, sorry, my video bubble's covering that last point there, but we need to ensure that AHPs who work with people who have had a stroke across all sectors of society should undertake training on return to work appropriate for the nature and level of services they provide. So we discussed a little bit about challenges in the first module and how access to training and education is quite patchy. And actually in the guidelines we're saying we should all undertake that training, not necessarily if and when we get it funded, it should be available to us all. And that means that we'd be able to support our patients as best as possible. So just really briefly wanted to just touch on the NICE guidance. The main reason why is because there's a really the real synergy between NICE guidance and the practice guidelines, because they were published in the same year, and trusts are kind of held accountable for how closely they meet national NICE guidance, and they shows how cost effective they can be. So it pretty much echoes what we've already touched on in the national guidelines, but should be managed actively, reviewed regularly, and identified as soon as possible. I think that's the biggest take home for this is, if we've got people who work on the acute unit, it's being able to identify those goals as soon as possible and communicating those wants and desires of patients to the following on teams in inpatient rehab or community rehab, and then those teams then continuing to pick that up and having that, joint up approach and that narrative throughout their stay in their stroke rehab services. So again, identifying and completing those comprehensive assessments of the demands of the job in the first place, but then also what any impairments are post-stroke, tailoring those interventions, education about the Equality Act and any support available. That might be, government schemes like Access to Work, which we'll come on to in the signposting session. Looking at workplace visits to help with that liaison between the person and the employer to help with those reasonable adjustments. So that is the practice guidelines and the NICE guidance, and then I just wanted to show you a little bit about the national service model for the integrated community stroke services. So this is kind of where the Squire funding is helping the ISDNs to meet this model. It's kind of like the gold standard of what we would like to be able to provide. What we recognise is that stroke can cause long-term difficulty. So it's looking at accessing from hospital and accessing from the community, having a core therapy team with appropriate access to services, and return to work services and VR services are included in that alongside, the psychological side of things. And there should be 3 pathways. So it's looking at patients that are able to manage independently, patients that need daily social care support, and patients that are discharged to residential or nursing home, and they should all get integrated community stroke support, as well as longer term support kind of at 6-month review, promoting that health and well-being that we've already discussed. So that's just a very, very brief insight into the ICSS, but it's more of a needs-based system, and looking at kind of VR over a longer term support, especially as timing for returning to work can be crucial in how successful and sustainable the actual return to work is. So yeah, I'm sure there's so much evidence out there, but I just wanted to touch on that really briefly so you just knew what the background was to some of the funding. Another piece of information that's really useful is the Stroke VR toolkit, which was also developed last year. So this is kind of like it's literally a working document, a step-by-step guide on the process of how to start the conversation about work. It can help you with supporting those reasonable adjustments and helping those discussions with employers. So it was endorsed by Royal College of OT, Chartered Society of Physio and Royal College of Speech Therapists, and they worked on it in conjunction. And pretty much they've used the context documents of those NHS models, the long-term plan, stroke service model, and then wider get evidence around VR. That's the British Society of Rehab Medicine Guidance, VR Association, Standards of Code of Conduct. This is actually on the shared Squire workspace, but there is, so you can get access to the toolkit, but there is also an e-learning module on e-learning for healthcare, which is just a bit of an introduction into the model itself, into the toolkit itself, sorry. So then it's included in the toolkit, so I just wanted to touch a little bit more about the RVR model for stroke rehab and how we can kind of set the scene for that. So it's 3 levels. Level 3 is at the bottom and level 1 is at the top, and then it kind of, as your complexity of need and intervention increases, you then work through the model. It's not necessarily linear in its way. It might be kind of a bit more of a dynamic process. They might move across the levels in not really a non-linear way. You might need to give some more specialist advice and then go back down to kind of your level 3 advice. So it's just kind of working out your individual at each stage. So if we think about level 3 being the bottom, so that's all stroke survivors, regardless of their age, should be offered appropriate advice, signposting and referral for more support to return to work. So that's everybody should be asked, do you work? And highlighted that work doesn't necessarily have to be paid work. Might be retired but main carer for family or children, or level 2 is your kind of your stroke, your local rehab, community rehab service or inpatient, but a lot of the time it's community by the time they've got to that level of being able to be back at home. And that's kind of like your ESD or your community stroke services. Also other agencies like local return to work services and looking at job retention. And they say a return to work plan should be implemented within 6 months. That's in the guidance. And then your specialist level is at the top. So that's any stroke survivor with a disability that prevents them from returning to and or return to work plan will take longer than 6 months. It's quite tricky at the moment with the specialist level because a lot of services aren't funded for longer than 6 months. Some are, some aren't, but it's a real monopoly. And I think it's also just want to mention that complexity of need might not necessarily be just because they've had a really, really complex stroke. It might be that they've got a complex job or they've got barriers, kind of employer barriers perhaps, that are making it quite hard for them to return. So that might be why you need to then tap into that more specialist level. So if we think about the bottom level, the level 3, so with this kind of 5 different approaches, so we want to ask, rehabilitate, educate, support and communicate. And ways that we can do that at bottom level, at level 3, is like we've just said about asking all patients about work and what matters to them. So regardless of whether they think they're going to return, we need to kind of give them that option. And it's where we're starting to understand what their rehab needs are. We're thinking about that initial assessment phase between the MDT. Providing information about stroke and work, might be signposting support services. At this point, that might be around benefits or statutory sick pay, that sort of thing. Support in terms of providing information about financial support, signposting to who they can get the fit note from. If they're at home, it might be that they need to go to the GP. If they're on the inpatient unit, it might be just asking the stroke consultant to discuss that with the patient. And there's charities with employment information as well. Lots of leaflets out there, Stroke Association and the charity Different Strokes, they do leaflets for the employer, leaflets for the patient around work and what to expect. Sorry again, my video bubble. Advise to stay connected with the employer and, if appropriate, occupational health. We're going to talk a little bit more about disclosure and what people should disclose or could or couldn't disclose. But we always recommend that at least to let them know that they've been unwell, and advising that. So if we think about the mid-level, again, those 5 different approaches, we just ask more detailed questions basically and start completing job demand analysis at that point, thinking about working on those work-related rehab goals, thinking about graded return to work, what might that look like. This is where you might do a little bit more hands-on education, maybe with the employer, helping the patient understand about employment law. Not, I wouldn't necessarily expect people to be doing know everything about employment law, because that's not our role, but it's just educating them of information that is out there to support them with if they need that information, really. In terms of support, it can be helping with reports. We've got allied health profession work report that's really useful, that I know a lot of teams use at community level. Directing for fit notes. I know a couple of teams in the stroke network, and some are looking at progressing, but when they changed the guidance in 2022 for allied health professions to be able to complete fit notes, there's a couple of teams at the OTs are doing those. So that might well be your local therapy teams. So it's worth asking them where they're up to with that. Access to Work is a government scheme that can support with financial grants to manage adjustments. So it might be that they can fund equipment or subsidise taxi if they aren't able to drive, that sort of thing. And then again, communicating, thinking about preparing patients for conversations with employers, doing those worksite assessments, liaising with employers, colleagues, that sort of thing. And then just that top level again, those 5 approaches, just thinking a bit more long term, slower stream rehab, managing your condition over time. And then the support and the communication is just that slightly higher level side of things. When I go on to the next module next week, I'm going to go into a little bit more detail of the nitty-gritty intervention that we would do. Great. So that was just a very brief introduction to the kind of policy and I guess the context documents around VR. Don't want to overdo it too much on the stroke guidance. I know that it's all available there for you to read if you wanted to have a look. Have a little think again at the end of the session, some keywords of what you might have learned. Ignore that bit, sorry, at the top that says use the Slido poll. That was just part of the live training session that we did. And there's some references there for if you do want to do some further reading. The toolkits up there and the national guidance and where you can access those, the stroke models and that RCOT research as well. Again, if you do have any questions, you can always drop me an email, and hopefully I'll look forward to seeing you at Module 3. Thank you.